The Tower Hamlets yearly asthma and allergy friendly school program aims to improve the care, safety, and support of children and young people with asthma and allergies in school, while helping to prevent avoidable emergencies and potentially life threatening incidents. As children spend a significant proportion of their day in school, it is essential that all staff feel confident in recognizing asthma and allergy symptoms, identifying signs of poor control, responding appropriately to emergencies, and understanding when concerns should be escalated to parents, carers, and healthcare professionals. Through awareness, education, and the implementation of best practice, schools can create a safe and more inclusive environment, enabling children and young people with asthma and allergies to thrive, participate fully in school life, and achieve their full potential. Asthma and Allergy Friendly program recognises schools that are committed to providing safe, supportive and inclusive environment for children and young people living with asthma and allergies. To maintain accreditation each year, schools are expected to demonstrate that they continue to meet the program's key standards. These include maintaining an up-to-date asthma and allergy policy, keeping an accurate and regularly reviewed registry of pupils with asthma and allergies, ensuring immediate access to prescribed emergency medication, including reliever inhalers and adrenaline auto-injector pens where required, having access to asthma and allergy care plans to identify all pupils, ensuring that all staff have completed and understand their role in supporting pupils by doing awareness training. Identify a named asthma and allergy champion, lead coordinator, and to promote best practice within the school. These standards ensure that schools are prepared to prevent avoidable incidents, respond effectively to emergencies, and support pupils to participate fully in all aspects of school life. Once you've achieved these yearly standards, send in the self-certification form and you will receive your certificate. An asthma and allergy friendly school is not simply a school with policies in place. It is a school where staff are aware, prepared, confident, and ready to act when children need the help. The purpose of this session is to increase awareness of allergies within school environment, build confidence in recognizing and responding to allergic reactions, and providing an overall of recent development in the national guidance, including the changes introduced through Benedict's law. Food allergies are a significant and growing public health concern. They are becoming increasingly common amongst children and young people, meaning that all staff are likely to support pupils with allergy during their careers. Current estimates suggest that 4 to 8% of children in the UK have at least one food allergy, which is approximately one child in every 13, or around two children in every class. Given the amount of time children spend in school, it is essential that staff understand how allergies can affect pupils, recognise early signs of allergic reactions, and know how to respond quickly and appropriately in an emergency. Prompt recognition and treatment can prevent a reaction becoming more serious and in some cases can be life-saving. This awareness session will help you ensure that the staff feel confident, prepared and confident in their role, contributing to a safer and more inclusive environment where all pupils with allergies can participate fully in school life. The new allergy guidance is statutory and applies to all schools in England. Schools have a legal responsibility to support pupils with medical conditions, including allergies, and to ensure systems are in place to keep them safe. A key driver for improving allergy safety has been the campaign following the tragic death of Benedict Blythe, a 5-year-old boy who died from an anaphylaxis at school in 2021. The campaign has highlighted the need for consistent approaches across schools, including appropriate staff training, clear policies, risk assessment, and access to emergency medication. The aim is simply every school should be prepared to recognise and respond to an allergic emergency quickly and effective. Good allergy management is not best practice, it is legal and safeguarding responsibility. To effectively support pupils with allergies, schools should have robust systems and processes in place. This includes ensuring emergency medication is available, staff are trained to recognise and manage allergic reaction, and clear policies are in place to guide practice. Every pupil with an allergy should have appropriate supported document with an individual healthcare plan, while schools should also maintain a wider allergy policy to set out the whole school approach to allergy management. All allergic reactions should be recorded and reviewed to identify any learning and reduce risk in the future. Finally, having a named member of staff responsible for allergy management can help provide leadership, oversight, and consistency across the school. You are now about to watch a short video on allergies to help increase your understanding what to do in an emergency. As you watch, think about how you would respond if pupils experience allergic reactions at school. Remember, earlier recognition and prompt action can save lives.
An allergy is the response of the body's immune system to normally harmless substances. In most people, these substances, also known as allergens, pose no problem. However, in allergic individuals, their immune system can identify an allergen as a threat and produce an inappropriate response. In the UK, 40% of all children have been diagnosed with an allergy. Allergy symptoms can affect all aspects of a child's day-to-day life, including their education, health and well-being, and social activities. The most common allergens are pollen from trees and grass, house dust mites, mold and damp, foods such as peanuts, tree nuts, milk, eggs and shellfish, furry animals such as cats, dogs, horses, rabbits and guinea pigs, stinging or biting insects such as wasps and bees, medicines. When a person comes into contact with an allergen, it triggers a response which causes release of substances and chemicals such as histamines into surrounding tissues. It is the release of these substances that cause the allergic reaction. These substances usually cause local symptoms in a particular part of the body, such as the eyes, nose, or a small patch of skin. Allergic reactions usually happen within a few minutes of exposure to an allergen, but symptoms can take up to 2 hours to present. Anaphylaxis is a potentially life-threatening, severe allergic reaction. It's a medical emergency and requires immediate treatment. The substances released within the body during an anaphylactic reaction are released into the bloodstream and cause a whole body response to the allergen, rather than a localized response seen during a milder allergic reaction. Symptoms of anaphylaxis usually occurs within minutes of exposure to an allergen. However, reactions can also take up to 2 hours. If a child is experiencing anaphylaxis, they must be given adrenaline via intramuscular injection into the thigh. This is called an adrenaline autoinjector, or an AAI for short. Most responses to allergens do not result in an anaphylactic reaction. However, if you are unsure, it is safer to administer the adrenaline and call 999 for assistance. Symptoms of an allergic response can vary from child to child, but the most common symptoms of a mild allergic reaction are rashes or hives visible on the skin, swelling or itching in specific areas of the body such as the skin, eyes, ears or lips, a runny nose or sneezing, an upset stomach, nausea or even vomiting. During an anaphylactic reaction, a child can experience life-threatening problems, which are often described as the ABC symptoms. These include A. Airway, swelling in the throat, tongue, or upper airways, tightening of the throat, a hoarse voice, or difficulty swallowing, excessive drooling or dribbling. B. Breathing, sudden onset of wheezing, persistent coughing, shortness of breath, noisy breathing, or breathing difficulties. C. Circulation, dizziness, feeling faint, sudden sleepiness, confusion, pale or clammy skin, loss of consciousness, and the child may report a sense of something terrible happening. When tragedies occur due to an anaphylactic reaction, It's usually because people have difficulty in differentiating the symptoms from those seen in a milder allergic reaction. That's why it's critical to be able to recognize the difference in the severity of symptoms. Anaphylactic reactions must be treated via intramuscular injection of adrenaline into the thigh, using an adrenaline auto-injector device, which is known as an AAI. Adrenaline works by preventing cells in the body from releasing the substances produced in response to exposure to an allergen and reduces the symptoms of an allergic reaction. If a child is in anaphylaxis, 1. Administer the AAI without delay and follow the child's individual allergy plan. Always bring the AAI to the child. Do not ask the child to go to where it is. Make sure you note down the time the adrenaline was given. 2. Help the child to lie down on their back and raise their legs. This will help to raise their blood pressure and reduce feelings of dizziness. If the child is feeling short of breath, they may benefit from being propped or sat up. Avoid any sudden change in posture, even if the child is feeling better, as this may cause a drop in blood pressure. 3. Call for an ambulance. Tell the ambulance staff this is an emergency case of anaphylaxis. Anaphylaxis. State the school's address, including the postal code. 4. Call the child's parent or guardian. The effects of adrenaline can wear off quickly, and the child may need to be given a second dose. If the child's symptoms have not improved within 5 minutes of administering the first dose, you can give a second dose of adrenaline in the other leg. It's very important that every child who has been prescribed an AAI has 2 AAIs on their person or placed in an easily accessible location. This is in case they require a second dose or the first dose has misfired. To be accredited as an asthma and allergy-friendly school, the school must have an emergency AAI device stored on site for these situations. If a child having an allergic or anaphylactic reaction also has a diagnosis of asthma, they may need to be given their blue salbutamol inhaler via a spacer after they've been given their AAI, as an allergic reaction can often make children with asthma wheezy. There is no need to remove clothing to administer an AAI, but take care to avoid buttons, zips, or thick seams on clothing when administering the AAI. There are 2 types of adrenaline auto-injector, AAI, but they contain the same medication called adrenaline, and they work in the same way to reverse the symptoms of an allergic reaction. If using an EpiPen, hold the EpiPen with the blue cap pointing towards ceiling and the orange tip pointing towards the floor. Blue to the sky, orange to the thigh. Remove the blue safety cap by pulling straight upwards. Place the orange tip at 90 degrees to the child's outer thigh. Push the orange tip firmly into the child's outer thigh at a right angle until you hear a click. Keep the AAI in place and hold firmly for 3 seconds before removing and safely discarding. If using a Jext pen, hold the Jext with the yellow cap pointing towards the ceiling and the black tip pointing towards the floor. Remove the yellow cap by pulling straight upwards. Place the black tip against the child's thigh at 90 degrees or at a right angle to the thigh. Push the black tip firmly into the child's outer thigh until you hear a click. Hold the injector firmly in place for 10 seconds before removing and safely discarding. Massage the injection area. Medication and AAIs should be safely stored with or close to the child, but not locked away in cupboards where it cannot be accessed quickly or easily. All medications should be stored in their original packaging in a cool, dark place at room temperature and kept out of direct sunlight. In secondary schools, some children will be capable to keep their medication on their person, but this needs individual assessment for each child. All medication have expiry dates, and these should be checked regularly. If you notice that medication is out of date or close to expiring, families should be informed to replace personal medication, and emergency generic medication should be replaced by the school as soon as possible. An AAI should contain clear, colourless solution. If the solution is discoloured or contains particles, it should be replaced, even if it's still within its expiry date. AAIs are single-use only and need to be disposed of correctly and replaced straight away. Used AAIs can be given to the ambulance crew or disposed of in a yellow sharps bin if you have one. School staff can only give generic or emergency AAIs in schools for children who have an allergy plan and parental consent. If the school's generic AAI has been used, it needs to be replaced as soon as possible. If you suspect that a child without an allergy plan is experiencing anaphylaxis, then call 999 and seek advice. Make it clear to them that your school has access to an emergency AAI device. A child with allergies will be given an allergy action plan upon diagnosis by a medical professional. The plan does not need to be updated unless there are changes to the allergens or medications. The plan includes symptoms of an allergic reaction and will state the details of the child's prescribed medication for both a mild or moderate and severe reaction. The plan also includes step-by-step instructions of how to administer an AAI. The administration of the AAI will differ depending on which device the child has been prescribed. Parents should bring a copy of their child's allergy plan into school, along with their child's allergy medication, which should be clearly labelled with their name and class. This plan and their medication should be easily and quickly available and accompany the child on school trips.
Allergic reactions can appear differently in different children and on different skin tones. Redness may be less obvious on darker skins, and rashes may appear purple, grey, darker brown, or simply feel raised and itchy. Staff should be aware of how allergic reaction can present across a range of skin tones to ensure prompt recognition and treatment. Mild to moderate reactions may require treatment with antihistamines in line with child's health plan. Recognizing anaphylaxis in a severe life-threatening situation will require immediate treatment. Signs and symptoms of severe anaphylaxis: you may have swelling of the lips, tongue, throat, or around the eyes, difficulty in breathing, wheezing, or persistent cough, difficulty speaking or swallowing, or could be worse where they may be feeling dizzy, collapse, or actually lose conscious. If a child is showing signs of anaphylaxis, follow their allergy action plan immediately. Administer the auto-injector pen without delay. Call 999 and state that this child is experiencing anaphylaxis. Stay with the child and monitor their condition until emergency help arrives. If symptoms do not improve, then a second auto-injector pen is available, and you should follow their allergy plan. Not all children will present with unconscious symptoms and may be able to communicate and explain their symptoms of anaphylaxis. If in doubt and you're not sure, it's safer to give the auto-injector pen. Antihistamines can be used for mild to moderate reactions, but they must not be used as a substitute for adrenaline in anaphylaxis. When anaphylaxis is suspected, administering the auto-injector pen and calling 999 immediately is the only action. Managing food allergies is a shared responsibility across the schools. Schools should ensure allergy information is available, pupils with allergies are clearly identified, and staff understand their role in keeping children safe. Parents should be encouraged to discuss dietary needs of catering staff, and pupils should be supported to make safe food choices by going through the menus to identify what the child can and cannot have. Particular care is needed when sharing food such as birthday treats or foods brought from home. These should be checked and risk assessed before being given to pupils. Staff should also remember that allergens may be present outside of meal times. Food ingredients are often used in classroom activities, cooking lessons, sensory play, craft, and science projects. For example, wheat-based pasta, flour, Play-Doh, cereal, dried beans, or egg-based products may trigger allergic reactions in some children. Alternative materials should be considered where required. Catering staff should understand food label requirements and how to prevent cross-contamination when preparing and dishing up meals. Allergens are not just found at lunchtime. Consider allergy risk in all activities involving food and food-based material within the schools. An individual healthcare plan, or IHP, is an important document that ensures a child or young person's allergy needs are clearly understood and consistently managed within the school setting. A pupil should have an IHP if their allergy has a functional impact on their participation in school, places them at risk of harm, or requires arrangements that are different from an additional to those provided for other pupils. This includes pupils who require emergency medication such as an auto-injector pen. The IHCP sets out the specific support arrangements that will be in place to keep the pupils safe. This includes details of their allergy, known triggers, measures to reduce risk, medication requirements, and the action staff should take if an allergic reaction occurs. The plan should be developed in partnership with parents or carers and, where appropriate, healthcare professionals. It should be accessible to relevant staff and reviewed regularly to ensure that it remains accurate and reflects the pupil's current needs. Where a child has an allergy action plan provided by a healthcare professional, this should be attached to or clearly referenced within the IHP. Anytime an updated action plan is reviewed, the IHP should be reviewed and amended accordingly. A well-maintained IHP helps ensure that staff are informed, prepared, and able to respond confidently and appropriately to support pupils with allergy, both in everyday situation and during an emergency. Risk assessments are an important part of keeping pupils with allergies safe and ensuring appropriate support is in place. Every pupil with an allergy should have an individual risk assessment, including those who are newly diagnosed or joining the school for the first time. This helps identify potential risk and any additional support that may be needed. When completed a risk assessment, consider the whole school day, including the classroom, dining hall, playground, school trips, after school clubs, transport, and special events. The assessment should identify any reasonable adjustments needed to reduce risk and ensure that the pupils can participate safely in school life. Relevant information should be shared with staff who need to know while maintaining confidentiality where appropriate. Risk assessments should be reviewed regularly, particularly after an allergic reaction, a change in treatment, or any significant change in a pupil's needs. Work closely with parents, carers, healthcare professionals, and the pupil helps ensure that plan is accurate, up to date, and effective. Good risk assessment identifies risk early, put support in place, and keeps children with allergies safe in schools. Being able to recognize anaphylaxis is only one part of responding to an allergy emergency. Staff must feel confident using an auto-injector pen. Schools and settings should provide opportunities for staff to practice using trainer pens. Trainer devices contain no needles or medicine and allow staff to become familiar with steps required during an emergency. The most important thing is to remember that an adrenaline is the first line treatment for anaphylaxis. Delaying treatment can increase the risk of the reaction becoming more severe. Staff should know where emergency medication is stored, how to easily access it, how to follow an allergy plan, when and how to call 999, the importance of remaining with the child until emergency service arrives. Regular practice and refresher training help to build confidence and ensure staff can respond quickly and effectively when required. Don't wait or hesitate. If anaphylaxis is suspected, administer the auto-injector pen immediately and call 999. If you're watching online, you may want to get some trainer pens to allow staff to practice that can be obtained free on the links below and can help boost staff's confidence. Creating an allergy environment is everyone's responsibility. Good communication, clear plans, and regular training can help children and young people be safe in schools. Staff should know which pupils have allergies and be able to identify their healthcare plans. Children, as this session comes to an end, take a moment to think about what actions you can take back to school. Do you know where emergency medication is kept and how quickly you could access it in an emergency? Time to review allergy needs of your pupils you work with and familiarise yourself with individual healthcare plans and allergy action plans. Think about activities that may involve hidden allergens, such as cooking lessons, sensory play, and craft sessions. Consider encouraging your school to run allergy emergency drills so staff can practice their response and build confidence before a real emergency occurs. Check your catering staff have had allergy training, as this is a requirement and should be readdressed with new staff and if there are changes in menu. Finally, share what you have learned today with colleagues and raise any concerns if you identify any areas where allergy safety could be strengthened. Now we're going to discuss asthma awareness session. Many children and young people do not always recognise when their asthma is poorly controlled or understand when they need medical help. Asthma attacks can occur anywhere at any time, and any member of staff has an important role to play in keeping children safe. This awareness session will help you to recognise signs and symptoms of an asthma attack, understand what good and poor asthma control looks like, knows how to respond appropriately in an emergency, understand the importance of care plans and emerging medication, and hopefully to feel confident in supporting children and young people with asthma throughout the school today. Together we can create a safe school, improve health outcomes and ensure that every child with asthma is supported and thrives within education. Asthma remains the most common long-term medical condition in children and young people across the UK, affecting around 1 in 11 children. Despite advances in treatment and management, asthma continues to place a significant burden on children, families, healthcare services, and schools. The UK continues to have poor outcomes compared with many other European countries, with asthma related deaths in children and young people remaining a significant concern. Many of the deaths are considered preventable through early recognition, effective treatment, and better self-management support. Health inequalities plays a major role in asthma outcomes. Children living in most deprived communities are far more likely to experience poor asthma control and require emergency hospital admission. This highlights the importance of targeted interventions and equitable access to high quality asthma care. Looking locally, Tower Hamlets has significant childhood respiratory health burden. More than 2,600 children are currently prescribed a reliever inhaler, equivalent to around 6% of children to the population. This provides an indication of the scale of respiratory symptoms and asthma management needs within the borough. It is also important to recognise that wheezing in young children does not always indicate asthma. Only 1/3 of preschool children will wheeze, and at some stage often as a result of viral infections, but only a majority will develop persistent asthma. Finally, while most people with asthma can achieve good symptom control with standard treatment, approximately 5% have severe asthma. This group experience a disproportionate number of exacerbations, hospital admission, and healthcare contact, requires more intensive specialist support. We do not fully understand why some children develop asthmas and others do not. Asthma is thought to result from a combination of genetic factors and environmental exposures. A child's risk is higher if there is a family history of asthma, particularly in parents or siblings. We also know that conditions linked to allergy, such as asthma, hay fever, and food allergies, are strongly associated with asthma. Children who experience significant respiratory infections early in life may be more likely to develop asthma symptoms later in childhood. Similarly, babies born prematurely can have smaller and less developed airways, making them more vulnerable to breathing difficulties. Environmental factors are also important. Exposure to tobacco smoke during pregnancy or in the home increase the risk of developing asthma and can make symptoms more difficult to control. Although these risk factors increase the likelihood of asthma, not every child with these factors will develop asthma, and some children with asthma have none of these known risk factors. To understand asthma, it is helpful to look at what is happening inside the airways. When someone with asthma is exposed to a trigger such as a viral infection, pollen, exercise or cold airs or cigarette smoke, the airways react in three main ways. Firstly, the muscles surrounding the airways tighten. This is called bronchoconstriction. All these muscles contract. The airways become narrow, making it harder for air to move in and out of the lungs. Secondly, the lining of the airways become inflamed and swollen. This inflammation makes the airways more sensitive and reactive to triggers. Even when a child is feeling well, some inflammation still may be present, which is why regular preventive treatment is so important. Thirdly, the airways can produce excessive mucus or phlegm. This sticky mucus builds up within the already narrowed airways, further restricting airflow. When these three processes occur together, the airways become narrow, irritated, making breathing more difficult. This leads to the classic symptoms of asthma, including wheeze, cough, shortness of breath, and chest tightening. A useful way of explaining this to families is to imagine breathing through a straw. The narrower the straw becomes, the harder it is to breathe. During the asthma flare-up, the airways behave in a very similar way. School play a vital role in helping children with asthma and allergies stay healthy, safe and able to participate fully in school life. Many common triggers can reduce through simple awareness and practical adjustments. Hay fever is a common trigger for asthma symptoms, particularly during the spring and summer months. Symptoms such as blocked nose, sneezing, itchy eyes, and poor sleep can affect concentration and asthma control. Encourage children to take prescribed antihistamine and nasal sprays before school can help reduce symptoms throughout the day. Physical activity is important and should be encouraged. However, some children with poorly controlled asthma may become breathless when climbing several flights of stairs during periods when symptoms are worsening. Reasonable adjustments such as lift access may help children move safely around the school. Strong smells and chemicals can irritate sensitive airways and trigger asthma symptoms. Examples include perfumes, air freshener, cleaning products, paint, glue, aerosols, and chemicals used during science lessons. Ensuring classrooms are well ventilated and be mindful of strong odours can help minimize exposures. Dust mite allergy is one of the most common allergy triggers in children. Dust mites are commonly found in carpets, rugs, beanbag cushions and soft toys, and any other soft furnishing. Schools can help by reducing unnecessary soft furnishing where possible and ensuring regular cleaning and vacuuming. Children with significant dust mites may benefit from sitting on a chair rather than carpets or classroom rug during group activities. Animal allergies can also trigger asthma and allergic reactions. Animal furs, feathers, saliva, and dander may all cause symptoms in sensitive children. It is important to consider known allergies before introducing classroom pets or arranging visits involving animals. Food allergies require careful management both inside and outside of the dining hall. Allergens can be present during cooking activities, baking sessions, and sensory play materials. Staff should be aware of individual health plan, check ingredients before activities, and take steps to avoid accidental exposure and cross-contamination. Finally, stress and anxiety can worsen asthma symptoms and make children feel increasingly breathless. Some children become trapped in a cycle where anxiety makes breathing feel more difficult, which then causes further anxiety. Encouraging calm breathing techniques, providing reassurance, and helping the child feel confident in managing their condition can make a significant difference. Small changes can make big impact. By recognizing asthma and allergy triggers and making simple adjustments, schools can create a safe environment, reduce avoidable symptoms, and help children thrive both academically and socially.
Air pollution affects us all. It can come from lots of places. It can affect every organ in your body from your first to your last breath. You can help reduce your exposure to air pollution by following these 5 simple actions. Air pollution is worse around busy roads. Getting even a short distance away from them can make a big difference. Encourage your whole family to walk, cycle and scoot more. Air pollution can be higher inside a car than outside. Sign up for air pollution forecast alerts to find out when it is most important for you to take pollution avoiding actions. If you do need to use a car, ask the driver to turn the engine off when the car isn't moving. To keep indoor air clean, use fragrance-free and low-chemical cleaning products. Follow simple steps to stop air pollution collecting in your home. By doing some of these actions, you will help reduce your exposure to air pollution. Less exposure to air pollution means healthier lives. To find out more, visit our website.
Children exposed to cigarette smoke are more likely to develop respiratory infections such as bronchiolitis, chest infections and pneumonia. These illnesses can lead to missed school days, increased GP visits, hospital admissions and disruption to family life. Children are particularly vulnerable because their lungs and immune system are still developing. They have smaller airways than adults and breathe more rapidly, meaning they inhale more harmful chemicals in proportion to their body size. As a result, tobacco smoke has a greater impact on respiratory health. For children with asthma, exposure to smoke can make symptoms significantly worse. They are more likely to experience cough, wheeze, chest tightness and breathlessness. They may require more medication, have more asthma attacks, attend emergency department more frequently, and are at greater risk of ongoing respiratory problems into adulthood. Exposure to smoke in childhood can also affect lung growth and development, resulting in lower lung function in later life. Many parents believe that smoking outside completely protects their children. While smoking outside is better than smoking indoors, it does not eliminate the risk. Harmful chemicals from tobacco smoke stick to the skin, hair, clothes and furniture, car seats and other surfaces. This is known as third-hand smoke. Children can be exposed to these toxins when they cuddle a parent, sit on furniture or touch a contaminated surface. To reduce exposure, parents should be encouraged to smoke outside, away from children, and ideally wear a dedicated smoking jacket that can be removed before coming back indoors. Washing hands, face, after smoking is also helpful. However, the only way to completely remove the risk is to stop smoking altogether. Stopping smoking benefits not only the parent but their entire family. Children experience fewer infections, improve asthma control, and healthier lung development. Support is available through local smoking cessation services, community pharmacies, and GP practices. Vaping and smoking. Although vaping is generally considered less harmful than smoking tobacco, vape aerosol is not simply harmless water vapor. It contains substances that can irritate sensitive airways and may trigger coughing, wheezing, chest tightness, and breathlessness in people with asthma. Some children and young people report that exposure to secondhand vaping aerosol can worsen their asthma symptoms. The aerosols can contain nicotine, flavouring, and other chemicals that may irritate the lungs, particularly in individuals who already have respiratory conditions. Parents who vape should be advised not to vape indoors, in cars, or around children. Vaping should take place outside and away from children wherever possible. Housing conditions can have a significant impact on a child's health, leading into worsening respiratory symptoms, increased illness and missed days of school. Under Arab's law, landlords are required to take action within 10 days of reported damp and mould issues. We can support families by directing them to the appropriate services and resources. Links within this pathway provide guidance for staff and information that can be shared directly with families. If landlords do not take appropriate action to address damp and mould, families can raise this issue with local environmental health departments. If concerns remain unresolved, a formal complaint can be made through the relevant channels. This pathway outlines the steps to help families navigate the process and access the support that they need. No child should be living at a home that negatively affects their health, well-being and education or ability to reach their full potential. One of the most common concerns raised by parents in school is whether a child's breathlessness during exercise is caused by asthma. It is important to remember that becoming out of breath during physical activity is especially during vigorous exercise. Children become breathless more quickly if they are less physically fit, have poor breathing patterns, are recovering from an illness, or exercising at high intensity than what they are used to. Not every episode of breathlessness indicates asthma. Weight can also have a significant impact on exercise tolerance. Children who are often overweight often experience breathlessness more quickly because the lungs and the chest wall have to work harder during the activity. Supporting healthy lifestyles, including balanced nutrition, appropriate portions, and reducing sugary drinks, can improve exercise tolerance and overall health. Exercise-related breathlessness is frequently misinterpreted as asthma. Before concluding that asthma is a cause, it is important to ensure that the child has good inhaler technique, is taking their preventer inhaler regularly as prescribed, has healthy breathing pattern, and that other factors such as fitness and weight have been considered. Children with asthma should be encouraged to participate fully in physical activity. Well-controlled asthma should not prevent a child from taking part in PE, sports, or play. If a child is consistently struggling to keep up with their peers despite good asthma management, or if symptoms persist despite appropriate treatment, further assessment may be required and specialist advice should be sought. Reliever inhalers should not be used routinely for children before exercise. They should be used according to the child's asthma plan when symptoms such as wheeze, chest tightness, significant breathlessness, or prolonged recovery occurs. Routine pre-exercise use should generally be reserved for children who have documented exercise-induced asthma symptoms that affects their ability to participate fully in physical activity. Being out of breath during exercise is often normal. The goal is for every child with asthma to participate fully in physical activity with symptoms well controlled and reliever inhalers used appropriately. It's really important that children learn good breathing technique from an early age, particularly if they are experiencing breathlessness during exercise or asthma symptoms. One of the best methods is diaphragmatic breathing, sometimes called tummy breathing. The diaphragm is the main breathing muscle and works more efficiently when children breathe deeply into the lower parts of their lungs rather than taking shallow breaths from their chest and shoulders. When children use diaphragmatic breathing, their lungs fill more effectively with air, they use less energy to breathe, they recover more quickly after exercise, they feel more in control when experiencing breathlessness. We encourage children to breathe in through their nose and out through their mouth. The nose warms, filters, and moistens the air before it reaches the lung, helping the airways work more efficiently. Many children naturally breathe only through their mouth when running or feeling breathless. This often results in fast, shallow breathing, which can make them feel even more out of breath and sometimes anxious. Slow, controlled breathing helps prevent the cycle. A useful way to treat diaphragmatic breathing to children is put one hand on their chest, one hand on their tummy. Breathe in through their nose, feel the tummy rise, then the chest. Breathe out slowly through the mouth and feel the belly deflate. Let's try this now. So deep breath in through your nose while your tummy pulls out. Draw your tummy in as your mouth exhales the air. Carry on going, taking a deep breath through your nose while your tummy inflates. Your tummy deflates and the air comes out of your mouth. Finger breathing can also be very helpful, particularly for younger children. The child traces their fingers while breathing in and out slowly. This gives them something visual to focus on and helps slow their breathing rate. Younger children may need an adult to guide them by tracing the fingers together until they become confident. Parents, carers, and school staff should observe how children breathe during exercise. Good breathing technique doesn't always come naturally, especially during sports and games when children are concentrating on the activity itself. Gentle reminders and regular practice can make a significant difference. Preventive inhalers are the main treatment used to control asthma and prevent symptoms from developing. They are usually brown, orange, purple, or grey in colours and contain an inhaled corticosteroid which reduces inflammation and swelling inside the airways. Unlike the blue reliever, which treats symptoms when they occur, a preventive inhaler works in the background every day to keep the airways healthy and less sensitive to triggers such as viral infections, pollen, exercise, and colds. Most preventive inhalers are taken at home and do not usually need to be kept in school. However, some children are prescribed Symbicort, which is a combined preventive and reliever inhaler. These children should have their inhaler available at school, and staff should follow their individual asthma action plan. One of the most important messages for families is that the preventive inhaler must be taken every day, even when a child feels completely well. Asthma inflammation is often present even when there are no symptoms. Missing doses increase the risk of flare-ups, asthma attacks, and emergency attendance, and increase reliance on the blue inhaler. A good way to explain this is that the preventive inhaler protects the airways every day, while the blue inhaler only treats symptoms after they have already started. Regular use of the preventive inhaler reduces inflammation, prevents wheezy episodes, reduces asthma attacks, improves day-to-day asthma control, reduces the need of reliever medication, supports normal participation in school, sports and activities. Because preventive inhalers contain a steroid medicine, children should rinse their mouth, brush their teeth after using, or have a drink of water. This helps prevent side effects such as oral thrush or sore mouth, hoarse voice, and throat irritation. This diagram shows how preventive inhaler works over time. Unlike the blue reliever inhaler, which works within minutes to treat symptoms, preventive inhalers gradually build up protection in the airways when they are taken regularly every day. The first effect is a reduction in airway inflammation. As the inflammation settles, the airway becomes less sensitive and less reactive to common triggers. As protection builds up, children experience fewer symptoms. This means less coughing, less wheezing, less breathlessness, and fewer episodes of chest tightening. One of the biggest signs of good asthma control is when children stop waking at night due to coughing or breathing difficulties and are able to sleep throughout the night. Good preventive inhaler adherence also means children are less likely to become unwell with asthma flare-ups. They are more likely to attend school regularly, participate fully in PE and sports, and enjoy normal day-to-day activities without asthma getting in the way. As asthma control improves, there is usually less need for the blue reliever. Children should be regularly relying on the blue inhaler if their preventive inhaler is working effectively. Better asthma control can also lead to fewer GP appointments, visits to A&E, lower risk of coming to hospital. A useful message for parents is a preventive inhaler works a bit like wearing a seatbelt. You do not wait for an accident to happen before putting it on. You use it every day because it protects you before a problem occurs. The blue inhaler, usually salbutamol, is known as a reliever inhaler. It works by relaxing the muscles around the airways, allowing them to open up and making it easier for air to move in and out of the lungs. It should be used when a child develops symptoms such as wheeze, persistent cough, chest tightness, or shortness of breath. It acts quickly and most children will notice improvement within a few minutes. The inhaler should always be used with a spacer. Spacers are particularly important in children as they help more of the medicine reach the lungs where it is needed, making the treatment more effective. Every child with asthma should have easy access to their inhalers and spacers at school and at home in case symptoms occur unexpectedly. Parents and school staff are sometimes concerned when children become shaky or notice their heart beating faster after taking the inhaler. These are common side effects of salbutamol and generally temporary and harmless. They usually wear off after a short period of time. Some children may be prescribed Symbicort, which is recognized as a red and white inhaler. Unlike most asthma inhalers, Symbicort can be used as both a preventer and a reliever inhaler. This means that the same inhaler is used every day to reduce inflammation and prevent asthma symptoms, and it is also used as a reliever symptoms if this occurs. This approach is sometimes referred to as Mart therapy. Because Symbicort acts as the child's reliever inhaler, it is important that it is readily available in school and accompanies the child in the same way that a blue reliever inhaler would work. School staff should follow their individual asthma plan, which clearly states how much the inhaler should be used. Parents should ensure that school staff are aware that the child uses Symbicort as their reliever inhaler, as some staff may expect all children to use a blue inhaler for symptom relief. In an emergency, the child's Symbicort is not available, then salbutamol can be given instead following the standard asthma emergency plan. And spacers are a simple but very important part of asthma treatment. They help children get the maximum benefit from their inhaled medication. When an inhaler is pressed, the medication leaves the inhaler at a high speed, approximately 70 miles per hour. Without a spacer, much of the medicine can hit the back of the throat, stay in the mouth, rather than reaching the lungs where it is needed. A spacer slows the medicine down and allows the child to breathe in and out more effectively. This means more medication reaches the lungs and less is wasted. Because the medication is delivered more efficiently, children often receive the intended dose and less medication is being deposited in the mouth and throat. This can improve asthma control and reduce the risk of side effects. For children using inhaled steroid, spacers are particularly important because they reduce the amount of medication left in the mouth and throat, helping to lower the risks and side effects of oral thrush, sore mouth, hoarse voice, throat irritation. Spacers also make inhalers easier to use correctly. Many children find it difficult to coordinate pressing the inhaler and breathing in at the same time. A spacer removes the need for perfect timing and improves drug delivery. It is important to remember that spacers are only used in metered-dosed inhalers, such as most blue, brown, orange, and purple inhalers. They are not needed for dry powdered inhalers, such as an Easyhaler or a Turbohaler. Using the correct spacer is just as important as using the correct inhaler. Different spacers are designed for different age groups and needs, and using the wrong spacer can reduce the amount of medicine reaching the lungs. For babies and young children, spacers are used with a face mask because they may not be able to form a good seal around the mouthpiece. As children get older, they can use the mouthpiece effectively. They can move the appropriate age-related spacer. A correct spacer, fitted spacer, improves medication delivery to the lungs, improves asthma controls, and reduces the risk of wheezy episodes and attacks. If a child has the incorrect spacer for their age or inhaler device, parents should be advised to contact their GP surgery to request the appropriate spacer. A template letter is available in the toolkit that schools can provide to parents to support this process. School staff should also check that spacers are cleaned, in good condition, and not cracked or damaged, as this can affect how well they work. If a child continues to have difficulty using their inhaler and spacer correctly, despite having the appropriate equipment, further support may be required. In these situations, school staff can contact the school nursing team or the child asthma nurse for additional advice and assessment.
To use your inhaler with a spacer using the tidal breathing technique, first hold your inhaler upright and take the cap off. Check there's nothing inside the mouthpiece. Shake it well. If your spacer has a valve, make sure the valve is facing upwards. Put your inhaler into the hole at the back of the spacer. Sit or stand up straight and slightly tilt your chin up as it helps the medicine reach your lungs. The next steps all happen smoothly in one action. Put your lips around the mouthpiece of the spacer to make a tight seal. Press the canister on the inhaler once to release the medicine and breathe in and out slowly and steadily into the spacer for 10 breaths. Remove the inhaler and spacer from your mouth. If you've been prescribed a second puff, keep the spacer away from your mouth. Wait a minute and shake the inhaler again, then repeat the steps. Some small volume spacers make a whistling sound if you are breathing in too fast. If you are using a large volume spacer, then you can use the same breathing technique. With tidal breathing, your spacer should make a clicking sound as the valve opens and closes. When you have finished, take the inhaler out of the spacer and replace the caps on both the inhaler and the spacer. If you've used an inhaler that contains a steroid, rinse your mouth with water and spit it out to reduce the chances of side effects. Using the spacer with the inhaler allows better delivery of the medications to the lungs, and getting the correct technique is key. Children under the ages of 5 would have a yellow spacer, which will have a mask. Children over the ages of 5 would have green and blue for older children. However, some younger children would be able to use a spacer with a mouthpiece at a young age if they are competent. If you don't use a spacer, the medication will go inside the stomach and not the lungs due to the speed the medication is delivered at, which is 70 miles per hour. Now we will demonstrate how to use the yellow spacer. To use the spacer with a face mask, check that the inhaler and the spacer mask is clear. Shake the inhaler and then place the spacer on the face of the child. Make sure you get a good seal around the child's face with the face mask. Press the canister on the inhaler once to release the medication and breathe in and out slowly and steadily into the spacer for 10 breaths. Remove the inhaler and spacer from the mouth. If they've been prescribed a second puff, keep the spacer away from your mouth, wait a minute and shake the inhaler again, and then repeat the steps. How to wash a spacer. To clean your spacer, first take your spacer apart and place it in a clean bowl and gently clean it with warm water and a detergent such as washing up liquid. And let it soak for 10 minutes. Although most spacers are cleaned in the same way, check the instructions for your spacer. Use warm water instead of boiling water, as boiling water may damage the spacer. Be careful not to scrub the inside of your spacer, as this can affect the way it works. It's best to leave a soapy film which prevents static. Static can make the medicine stick to the side, so it's hard to breathe in. If you're not sure, check the information leaflet that comes with your spacer. Leave your spacer to air dry, as this can also help to reduce static. When it's completely dry, put your spacer back together, ready for use. Wipe the mouthpiece clean before you use it again. When you are not using your spacer, storing it properly will keep it in a good condition, keeping your spacer away from dust and liquids. Keep your spacer in a breathable bag such as a cotton or a cloth bag so it doesn't get scratched and so small objects don't get stuck inside it. Don't put your spacer in a plastic bag as this will cause it to build up static. Spacers need replacing every year depending on how often you use it. Some spacers need to be replaced sooner. Ask your GP or pharmacist if you're not sure.
Recognising the challenges associated with obtaining and updating individual plans, we have developed a streamlined approach to ensure the burden on both schools and families. The standard asthma plan is designed to replace existing individual plan and aims to simplify the process for school and families. You no longer will need to spend time and effort chasing up information from GPs and families. Once the individual plan has expired, families can complete the new standard plan and tick their triggers and sign they are happy for you to use your emergency inhalers. The plan will remain valid for the entire duration of the child's time in school, eliminating the need for repetitive documentation. It is crucial to keep a copy of the plan for reference in case it gets lost. If you have any new students, then a standard plan should be used for all students entering the school. This ensures a consistent and efficient approach to managing asthma-related concerns. Student involvement. In cases where students are deemed competent, they can sign the standard asthma plan themselves. This is particularly applicable for secondary age school, where obtaining signatures from parents can be a lot more difficult. When going on residential trips, parents are required to fill out a medication administration form. Additionally, this is essential to ensure that the asthma plan accompanies the child during the trip. If you do have individual plans already in place, they are still valid and you can still use them. The standard asthma plan is to give consent to use your emergency supply and when you're having difficulties obtaining the individual one from the parents. The standard asthma plan is designed to provide a clear guidance for school staff when a child develops asthma or wheeze symptoms in school. It also helps ensure that everyone responds consistently and safely. When discussing the plan with parents, it is important to go through each section and ensure they understand how and when their plan will be used. Parents should sign the plan to give consent to use school's emergency salbutamol. The plan can be used in two ways. It can act as the child's individual emergency plan, or it can be used as consent form allowing school staff to use school's emergency inhalers if they are unable to obtain a separate individual asthma plan. The first step is to always recognise the signs and symptoms of wheeze and asthma. This may include coughing, wheezing, shortness of breath, difficulty in speaking, chest tightness, or reduced ability to partake in activities. If symptoms occur, staff should stay with the child, keep them calm, sit them upright, and obtain their inhaler and spacer as quickly as possible. Anxiety and panic can worsen breathing difficulties, so staying calm and reassuring them and making sure that they have good breathing technique will also help. When administering the reliever inhaler, always use the spacer. One puff should be given at a time, followed by 10 breaths through the spacer. This ensures that the medicine reaches the lungs effectively. An important update is that we no longer use weaning plans for salbutamol following an asthma attack or wheeze episode. Children should only receive salbutamol when they have symptoms and need symptom relief. If a child continues to need regular reliever inhaler during school times, this is a sign that they require medical review. A child may use up to 6 puffs when needed during recovery, but should not require more frequently than every 4 hours. If a parent asks school staff to administer regularly high doses of reliever inhaler throughout the day, staff should advise the parent that the child needs an urgent review by the GP, urgent care or A&E, depending on how unwell they are. Ongoing regular reliever use suggests that the wheeze episode or attack may not have fully resolved. If symptoms worsen, some children may be advised by a healthcare professional to increase to 10 puffs of salbutamol while awaiting medical assessment. If school is being asked to give this level of medication, parents must ensure the child receives urgent medical review the same day. School staff should not feel responsible for determining whether a child needs to go to the GP, urgent care or A&E assessment, but they should clearly communicate concerns to parents, explain that frequent reliever use indicates the need for urgent medical review. Finally, if there is no improvement, symptoms are worsening, the child is struggling to talk, becomes exhausted, or there are any concerns about their safety, follow the emergency section of the plan and call 999 immediately. Mart therapy has a different asthma plan, and it's important to remember that not all Symbicort inhalers are used in exactly the same way. Always check the child's individual asthma plan before administering extra doses. The asthma plan will tell you how many maintenance doses a child should take every day and how many extra doses can be used when symptoms occur. Children prescribed Symbicort MDI, which is a metered-dose inhaler, use the inhaler with a spacer and may have different dose instructions from children prescribed a Symbicort turbo inhaler, which is a dry powdered dose inhaler. For this reason, staff should never assume that all children on Symbicort follow the same plan. Schools should ensure that the child's current individual asthma plan is easily accessible and that staff know where to find it. The green section is when the child is well and their maintenance medication. Amber, symptoms are getting worse. They may have, depending on the inhaler, they can require between 4 and 12 puffs in 24 hours. Red is severe asthma attack and they can have 6 to 12 puffs. You can see the doses vary different and the individual asthma plan will state what you need to do.
Here's how to use your turbohaler. The first time you use your turbohaler, hold it upright, take the lid off and twist the coloured bottom. Twist it all the way as far as it'll go and then twist it back again until you hear it click. This click means it's ready to use. Sit up straight and hold your inhaler at a slight tilt, as if you're going to take a sip of a drink. Don't tip it upside down because some of the medicine inside the inhaler can fall out. The next step will be all in one go. Do a few normal breaths and then do one big breath out. Put your mouth around the inhaler and take a big breath in, sharp and fast. Keep your mouth closed and hold your breath for 10 seconds. Once you've finished, twist the lid back on, and after that, you can wash your mouth out or brush your teeth. Your inhaler will show you how many doses are in it. Let your parent or guardian know when you see a red strip in the window, as this means your inhaler will run out soon.
Any school trip, it is essential to ensure that the appropriate healthcare documents are available. Staff should have access to the child's asthma plan and where relevant individual allergy action plans. These plans provide clear guidance on what to do if symptoms develop and an emergency occurs. Children with food allergies should be identified before the trip so that catering providers and supervisor staff are aware of the dietary requirements and allergy risks. Consider meal arrangements, snacks, and any activities where allergens may be present. All routine medication must have a completed and signed medication consent form in accordance with the school medicine policy. Staff should check that consent covers any medication that may be needed to be administered during the trip. Children and young people should bring all medication that they require, including their relievers, spacers, preventers, inhalers, or if they have any allergy medication such as antihistamine and auto-injector pens. Always check that there is enough medication to last a whole trip and ideally have spare medication available. Inhalers should be checked to ensure that they are in date and not empty. While inhalers do not have dose counters in all cases, gently shaking the canister may help identify whether medication remains inside, although a dose counter is the most reliable method. If a child uses a steroid preventer inhaler during the trip, they should rinse their mouth, brush their teeth, or have a drink of water after to reduce the risk of side effects. Good preparation before the trip reduces the risk of emergencies and helps ensure all children can participate safely and enjoy the experience. Schools are often the first to notice when a child's asthma is becoming poorly controlled. Changes in symptoms, attendance, or activity levels can provide important early warning signs that a review is needed. If a child requires their blue inhaler more than 3 times a week at school, this suggests that their asthma may not be well controlled. While occasionally use is expected, frequent reliance on a reliever inhaler indicates that the child's asthma management plan needs to be reviewed. Frequent absences due to asthma, wheeze, chest infections, or breathing difficulties should also prompt concern. Poorly controlled asthma can significantly affect attendance, learning, and overall well-being. Children with well-controlled asthma should be able to participate fully in sports. If a child regularly sits out of activities, struggles to keep up with their peers, or requires frequent rest due to their asthma symptoms, parents should be advised that a medical review is needed. Schools may also notice increasing coughing, wheeze, breathlessness, or growing reliance on the reliever medication. These are all signs that asthma control may be deteriorating. In these situations, staff should contact parents and recommend that they arrange for asthma review with their GP, practice nurse, or asthma specialist. Early intervention can prevent symptoms worsening and reduce the risk of asthma attack. If you do have any children that you have concerns using their regular inhaler, then I'm happy for you to email me with your concerns, and then I can see whether they need to be reviewed by the GP or within the asthma service. We have come to the end of the session, and there are a few key messages that can make a significant difference to asthma management in school. First, regular checks that all medications are in date and available when needed. This includes both children's own inhalers and spacers as well as school emergency supply. Expired or missing medication can delay treatment during an emergency. All staff should know where emergency medication is stored and how to access it quickly. In an asthma emergency, every minute matters, so inhalers and spacers should be easily located and not locked away. Every child with asthma should have an updated asthma action plan available in school. This ensures staff knows how to recognise symptoms, when medication should be given, and what to do if the child's condition worsens. Using the correct spacer is essential. Different ages and inhalers require different spacers, and using the wrong spacer can reduce the amount of medication reaching the lungs. Children and families should also be encouraged to clean spacers regularly, particularly if salbutamol is used frequently. A clean spacer improves medication delivery and helps the device work effectively. Good breathing habits are another important part of respiratory health. Teaching children diaphragmatic breathing and encourage them to breathe in through their nose and out through their mouth can improve exercise tolerance, reduce anxiety-related breathlessness, and help recover following physical activities. An asthma-friendly school is one where staff are confident in recognising symptoms, responding to emergencies, supporting children to access medication, and encourage full participation in school life. Finally, trust your instincts. If you have concerns about a child's asthma control, frequent reliever inhaler use in school, issues around attendance, sleep disruption, or ability to participate in exercise, seek advice and refer them to the appropriate healthcare professional or asthma nurse service. taking the time to complete this allergy and asthma awareness session and helping to improve support for children and young people with asthma and allergies in your school. By increasing your knowledge and confidence, you can play a vital role in recognising symptoms early, reporting appropriate emergencies, and helping children manage their asthma and allergies effectively so that they can fully participate in school life. Please remember to inform your asthma and allergy champion that you've completed this session. Recording staff awareness helps demonstrate your commitment to good asthma and allergy management and supports your school's progress towards asthma and allergy friendly school status. If you have any questions, concern, or would like to raise advice about a child with asthma and allergies, please do not hesitate to contact us. Our details are on the main YouTube page. Thank you for helping children with asthma and allergies stay safe and healthy and ready to learn. Together we can improve asthma and allergy outcomes, reduce avoidable attacks, and ensure every child could achieve their full potential.